So what do you find there? Is it a narrow QRS complex or a broad QRS complex? Any one of you? Saroj, would you like to try?
Yes, sir. Yes, sir. Sir, it is a broad QRS complex, left bundle branch block morphology,
Very
the
good.
atrial fibrillation
Okay, very good.
with pre-existing bundle branch block.
Yeah, this patient is what is the axis of the QRS complex?
Yes, sir. One minute, sir. Sir, this is left axis, sir.
Okay. What may be the explanation for left axis deviation in a patient with LBBB?
So though we don't say separately as a left anterior hemiblock, but sir, it may be sir complete left bundle branch block with left anterior hemiblock.
No, when there's
Can we say, sir?
Complete,
No.
when you are saying that there is a complete left bundle branch block, the
We don't say, no, sir.
left anterior physical and left posterior physical both are involved.
Yes, sir. Yes, sir. Yes, sir. So, sir, here the explanation will be.
Any one of you? Anybody would like to give a comment? What may be the explanation for the left axis deviation in a patient with the left bundle branch block? One of the explanation, yeah. Anybody who would like to give a comment or would like to answer the question? Anybody? One of the explanations thought of is that it may be associated with the left bundle branch block. If associated with left ventricular hypertrophy, sometimes you can get associated left axis deviation. So, in a patient with left bundle branch block, there is left axis deviation. You can always think of a possibility of associated left ventricular hypertrophy also. Okay, right. Next, we'll go to the next one. Okay, what is this? Again, you should go step by step. Is it a narrow QRS or a broad QRS?
So this is a wide QRS complex tachycardia.
Okay.
With right bundle branch block morphology.
Okay.
Sir, sir, so I have to differentiate.
It is not classical.
Classical, not classical, sir.
Not sir, classical, because in classical.
This is ventricular tachycardia.
Why did you say it's ventricular tachycardia?
Sir, this is because, sir, in between, sir, 1 minute, sir.
Sir, AV dissociation is inside V3.
Yes, sir.
Very good. In V1, if you look at V1 is the best one. You can see previous independent of the
QRS complex.
So you can P seen here, you can see PO here, you can see PO independent of the QRS complex. So that what are the electrocardiographic features of ventricular tachycardia?
Sir, concordance pattern, capture beat, fusion beat, and sir, intrinsic deflection more than 40 millisecond early, and sir, extreme right axis deviation.
No. What will be the duration of the QRS complex in a patient with ventricular tachycardia?
Sir, more than 120 millisecond?
No, not 120 is not enough. More than 140.
140. Yes.
Some people even recommend that it should be more than 150.
Okay.
So when the QRS duration is more than 150, it is almost certain that it's ventricular tachycardia, but it should be at least 140. Okay, then AV dissociation. Can you think of any other differential diagnosis in this patient? I agree with you that.
Junctional.
Yeah, you're right.
So junctional tachycardia.
Junctional tachycardia with
sir retrograde P or sir pre-existing bundle branch block.
okay, pre-existing bundle branch block, yes.
So pre-excitation.
Can this be junctional tachycardia?
Yes, a retrograde P wave we have to see, but not in all, sir. It is not seen in all.
No, here what you're seeing is a sinus P. This is a P wave.
Yeah.
And you can see here the P wave in V1 is classically the sinus P pattern. So it is a sinus P. So in a patient with junctional tachycardia, how will you explain the sinus rhythm or sinus P wave?
Sir, if they are retrogradely conducted and reset, if one side is blocked and another side, sir, if it is retrogradely conducted, then can happen, sir.
No, what should happen? Retrograde?
Sir, retrograde conduction of the P waves.
No, retrograde conduction of the P wave. Junctional tachycardia with a retrograde block.
Yes, sir.
When there's a retrograde block, the impulse from the junction do not travel to the atrium. So atrium is controlled by the sinus node.
Yes, sir. Yes.
So the sinus node will control the atrium, and because of the tachycardia, the junction will control the ventricular rate. So it can be a proximal junctional tachycardia with retrograde block. And usually junctional tachycardia has got a slower rate. What is the rate in this patient?
It is around 100.
Yeah, little more than 100. It's around 120.
Yes, sir.
120. So the rate is lower on the lower side. Of course, 120 is enough to diagnose ventricular tachycardia. But when there is a slower rate, then you can easily make out the AV dissociation, and so most likely there is a retrograde block, and all those put together, you can always consider the possibility of a junctional tachycardia also. But looking at V1, I would like to go more in favor of ventricular tachycardia because V1 is not classical right bundle branch block pattern, and in some of the complexes, initial part of the initial R wave is sometimes taller than the R dash wave. That is a point very much in favor of ventricular tachycardia. What are the clinical signs of AV dissociation? 3 clinical signs of AV dissociation. When there is AV dissociation,
irregular canine waves, sir.
Very good. What are the 3 clinical signs of AV dissociation? One
Variable first heart sound.
Variable first heart sound, yes. Varying first heart sound.
Pulse.
Varying pulse volume.
Yes, sir.
Varying pulse volume. So whenever you find, when somebody asks you what are the clinical signs of AV dissociation, there are 3 clinical signs. 1, varying pulse volume. 2, irregular cannon waves. 3, varying intensity of the first heart sound. So these are the 3 clinical signs of AV dissociation. So this is a case of ventricular tachycardia, differential diagnosis, junctional tachycardia with retrograde block. Okay, what is this? What are the interpretations that you can give from the looking at this mitral flow pattern?
Sir, here, sir, E by A ratio, it is more than 2.
Okay.
Sir, so it is a diastolic dysfunction, but
Very
sir,
good.
we have to see that whether the deceleration time is, if it is very low, then sir, it will go in favor of restrictive pattern.
Yeah. Here the it is given the mitral deceleration time is 114.
Sir. Normal is, it is less. Sir, I don't remember the exact deceleration time.
Anybody would like to say what will be the normal deceleration time? Any one of you? Usually the normal deceleration time is around 180, 200. And anything, sometimes even maybe above 200. But the deceleration time below 160 indicates impaired LV relaxation. And when it goes below 140, it indicates restrictive pattern. Why does the deceleration time become less in restrictive pattern? Why it becomes why the deceleration time shortens? What is the reason?
In case of restrictive patterns, the early diastole is very fast.
Yes.
That's why, sir.
Why it is fast?
So because in restrictive patterns, late diastole is why fast, sir?
Why is there is a rapid flow? Because you are finding the E wave is very high, very tall. It has more than 1.5.
Yes.
So why is it that in a patient with the restrictive pattern there is a high E velocity?
So during early diastole, the LV relaxes and then it gets halt. That is the pathology in restrictive cardiomyopathy, sir.
Anybody who would like to explain why the E velocity is high in a patient with a restrictive pattern? In a restrictive pattern, what happened to the left atrial pressure?
Sir, increased, sir.
Increases. So when the mitral valve opens, there is a high gradient or there is a significant gradient between the left atrium and the left ventricle, resulting in a very rapid filling of the left ventricle because of the high left atrial pressure. It is a high left atrial pressure which makes the E velocity very high. Then what is the hemodynamic mechanism which makes the deceleration time shorter? It is because when the blood fills
The early rapid filling phase is fast.
Yes. When the rapid filling occurs, what happens? What happens to the LV diastolic pressure when there is a restrictive pattern? When there is a restrictive pattern, when the blood flows into the LV diastolic pressure rapidly rises, very rapidly. And it rises very rapidly and equals or exceeds the, it may not exceed, it may almost equal the left atrial pressure, resulting in a very sharp deceleration time for the E wave. So it is because of the rapid rise in the LV diastolic pressure, which culminates in a very short deceleration time. And when it is below 140, you can even consider the possibility of a grade 3 or a grade 4 LV diastolic dysfunction. What do you mean by grade 3? What are the features of grade 3, grade 4 diastolic dysfunction, and what is the difference between grade 3 and grade 4?
Sir, in case of grade 4, sir, AR will be increased, sir.
Okay. In grade 3 also AR will be increased.
Yes, sir. But sir, with Valsalva, we have to differentiate. In case of 4, there will be no further change of the AR with Valsalva.
Yeah. In patients with grade 3, what happens with Valsalva?
Sir, AR timing will be increased. But in case of grade 4, there will be no change with Valsalva.
So the pattern changes when there is a Valsalva. See, the grade 3 and grade 4 is mostly defined by whether it is reversible or irreversible. So in the grade 4, the changes are so advanced that it is not reversible. While in grade 3, still it is reversible, which is a favorable sign. And this can be tested by doing a Valsalva maneuver. When you do a Valsalva maneuver, the deceleration time slightly gets prolonged. As you rightly said, the flow pattern of the pulmonary veins improve. All those things will definitely tell you that with the Valsalva maneuver, there is a reduction in the LV filling pressures. So an improvement of the filling pressures by a Valsalva maneuver indicates that the changes are reversible and it is a grade 3 LV diastolic dysfunction. While when with the Valsalva maneuver, where there is no change in the pattern, that usually indicates the changes are irreversible and it is grade 4. So in this patient, there was no change at all, and this indicates a grade 4 diastolic dysfunction. So the grade 4 diastolic dysfunction is diagnosed by 1, the EA ratio more than 2. Here it is 4.57. You can simultaneously look at E prime also, and usually it will be more than 15. The E wave deceleration time will be less than 140. When you look at the pulmonary venous flow pattern, the velocity, two things you can look at. One is the velocity of the air reversal, and two, the width of the air reversal. Can you tell me at what velocity will you take it as considered as abnormal, and what will be the relationship of the duration of the air reversal with that of the mitral A wave? Any one of you? What should be the velocity of the air reversal for you to diagnose that there is a restrictive pattern? Velocity should be more than 35 centimeters per second. If the velocity of air reversal is more than 35 centimeters per second, that indicates restrictive pattern. And you can also look at the duration of the air reversal. That is measured by the duration of the air reversal minus the duration of the mitral flow A wave. That should be more than any one of you. The prolongation of the air reversal is one of the features of restrictive filling pattern. So to diagnose a restrictive pattern, the duration of the air reversal minus duration of the A wave across the mitral band should be
20, sir.
equal to or more than
20, sir.
30 milliseconds. It should be equal to or more than 30 milliseconds. So if it is equal to or more than 30 milliseconds, or if the air reversal is more than 35 centimeters per second, both are indicators that there is a restrictive pattern. So all these things will help you to diagnose LV diastolic dysfunction. And you can always look at the EE prime also. In this patient, the EE prime was 40. Anything above 15 can be considered as highly suggestive of a restrictive filling pattern of the left ventricle. So here this patient had an EE prime of around 40. I think it was 36 or so. So this is a grade 4 LV diastolic dysfunction. This is a Doppler recording of the pulmonary venous flow. So you tell me what are the waves, and this is best seen here. This is the complex which shows the waves best. You tell me about the waves, the height of the wave, and what are the abnormalities that you can detect from pulmonary venous flow tracings. What are the waves in pulmonary venous flow?
So two
Yeah.
positive wave and one negative wave.
Yes.
S and D.
S and D. The one
Yes,
which is getting recorded during systole is the S wave. The one which is being recorded during diastole is the D wave. And there is a air reversal also. Okay. And normally which wave is stalled and which wave is less stalled? Is S more prominent than
Yes,
D
sir.
or D more prominent than
The
S?
S more prominent than D normally.
Yes. Yeah, normally S is more prominent than D. Why it is so? That
Sir,
during diastole there is a very good ventricular filling and blood can flow easily into the left atrium. Then why is it that S is more prominent than D wave?
due to sucking effect of the LV
Not
and
not
pulling down of the mitral valve.
Yeah, not because of the sucking effect of the LV, it is because of the relaxation of the left atrium. See, the air wave is recorded at a time when the atrial contraction is over, it emptied its contents into the left ventricle and then the atrium relaxes. When the atrium relaxes, there is a sucking effect and the blood is drawn into the left atrium. So, and also as you rightly said, towards the late phase of the systole, there is a pulling down of the mitral valve that also will have a sucking effect on the flow of blood from the pulmonary veins into the left atrium. So the A wave is normally A wave is taller than the B and the D wave. Can you tell me one of the conditions where D wave can be taller than the A wave? Sorry, S wave.
The mitral regurgitation.
Yes, very good. In mitral regurgitation, usually S wave is dwarf and D becomes more prominent. Because of the mitral regurgitation, the flow from the pulmonary veins into the left atrium is restricted, and then you can have much dwarf V wave. In acute mitral regurgitation, even you can get a reversal of the flow. And next is the this is the S wave, this is the D wave, and S wave is taller than the D wave, and this is the this is the air reversal. And the air reversal in this patient is around little less than 30 centimeters per second. So it may be 28, something like that, which can be passed off as normal. So this is the S wave, this is the D wave, and this is the air reversal. And air reversal can become more prominent where the velocity can go up and the duration also can become longer, and the velocity more than 35 centimeters per second qualifies for significant air reversal. And these patients can have a velocity, the velocity can be more than 35 centimeters per second. And if you look at the duration of the air reversal, the air reversal minus the mitral air wave will be more than equal to or more than 30 milliseconds. So these are the criteria for you to diagnose associated LV diastole dysfunction. What do you find there? And which is the view? What view is this and what is the finding? What is the view? Is it the left side LAO view or an RA view?
So this is a LAO view.
LAO. Why do you say it's an LAO view?
No, sir. So spine is posterior, no, sir? So that's why, sir. LAO.
Beg your pardon?
Sir, spine.
Where is the spine? Here is the spine.
Sir, spine is on the right side, sir.
Yeah. So it is a. When the spine is on the right side, it is an LAO view.
LAO view.
It is an LAO view. You are right. It is an LAO view. And what is the purpose of taking an LAO view? And what is when you are doing an LV injection? In an LV injection, when do you take LAO view? When do you take RAO view?
So to see VSD, we take LAO view.
Yeah. When you want to separate out right from the left side, you want to separate out LV from RV, you want to separate out LA from RA, then you do an LA view with a cranial tilt. So that will help you to differentiate LV from RV and LA from RA. When you are trying to separate out atria from the ventricle, where you are looking for mitral regurgitation or some abnormality between the left atrium and the left ventricle, then you have to do an RA view. RA view helps to separate atria from the ventricle. LA view helps to separate right side from left side. So right side chambers can be separated from the left side chambers. So here you can see the dye is injected into the which
LV.
ventricle?
LV.
LV.
With
Injected into the left ventricle, and there is a through the VSD,
Yes,
the
sir.
right ventricle is pacified. And this is the case of what VSD is there? Is it a perimembranous VSD, muscular VSD? What
The
is it?
muscular VSD.
It's more like a muscular VSD because it is lower down and it is a muscular VSD. Very good. Okay. Extra chest.
So there is a calcification is seen in the region of PDA.
Now, let us find out whether somebody else would like to take up the challenge. Anybody else? Anybody who would like to discuss the case, discuss the X-ray? Anybody? Anybody who would like to discuss? No, you should come forward.
Sir,
What is your name?
Dr. Jagdish.
Jagdish. Okay, Jagdish. Yeah, where are you from?
Sir, Mumbai, sir.
Mumbai. In which institution are you undergoing your training?
Just Look Institute.
Just look. You are doing DNB.
Yes, sir. Yes, sir. DN.
And you are with who are the? Are you with Dr. Mehta?
Yes, sir. Yes.
Oh, very good. Okay. So read the X-ray.
Sir, chest X-ray, PA view,
Oh,
situs solidus, pleocardia.
okay.
There is enlargement, right atrial enlargement, sir,
Okay.
and prominent pulmonary artery.
Pulmonary segment is prominent. Very good. What are the
Yes, sir.
whenever you see a pulmonary segment in the X-ray chest, what are the possibilities?
Pulmonary stenosis. Pulmonary stenosis.
Okay, post-stenotic dilatation. Very good. 1, 2.
Yes, sir. Poston.
Second, as a group.
Yes.
How can the pulmonary artery segment be dilated?
Sorry, sir.
What are the situations where the pulmonary artery segment in an X-ray chest will be dilated? One you have already said, post-stenotic dilatation.
Dilatation.
Idiopathic dilatation of pulmonary artery.
Okay,
Absent pulmonary.
idiopathic dilatation of pulmonary artery.
Absent pulmonary valve syndrome.
Okay, absent pulmonary valve syndrome where there is a stroke volume increases. Why there is a in absent pulmonary valve there is a prominent pulmonary artery segment?
Because they will be associated with regurgitation also, sir, and that regurgitation, large volume of blood is ejected, sir.
Yeah, there is a stroke volume increases, and they got usually associated with pulmonary stenosis also. So they will have pulmonary stenosis, pulmonary regurgitation. Pulmonary regurgitation will result in large volume of blood regurgitating into the right ventricle, resulting in a higher stroke volume, and the pulmonary stenosis will result in a jet getting into the pulmonary artery. Both contribute to the development of post-stenotic dilatation. Okay, right? Yes. What else? No, two important causes you are not mentioning.
ASD, sir.
Which one?
Sir, ASD.
Don't say ASD.
PH.
You
Sir,
put
PH, sir.
put it as
PH.
a category. Left to right
left
shunt.
to right shunt, sir.
Left to right shunt. Examples ASD, VSD, PD. All three can give rise to prominent pulmonary segment and PH, pulmonary hypertension. So whenever you look at a patient with prominent pulmonary segment, there are four conditions that you should suspect. One is increase in the pressure, pulmonary hypertension. Two, increase in the flow, left to right shunt. Three, post-stenotic dilatation. And four, idiopathic dilatation of the pulmonary artery. The absent pulmonary valve is actually comes under the category of post-stenotic dilatation because and also there is higher stroke volume. If you want, you can include that also, absent pulmonary valve. So these are the 5 conditions where you can get a post-stenotic dilatation, or rather dilatation of the pulmonary artery segment. So here the pulmonary artery segment is prominent, and you have to give the reason why it is prominent. Agrees? Are you there or?
Yes, sir, I'm here.
Eh? Do you have any clues about is the patient having increased pulmonary blood flow? How do you diagnose increased pulmonary blood flow?
Sir, increased end-on vessel, sir. It is to get more in more in on a single lung field, or together is more than 5 in both the lung fields, sir.
Okay. If it is a single ventricle, if we are looking at if you are looking at one lung field,
more than 3, sir.
More than 3. And if you are looking at both the lung fields, it should be more than
5, sir.
5. Okay. Yes. So, do you think that this patient is having increased pulmonary vascularity?
There is no evidence of. There are few end-on vessels in the right hilar, sir.
Yeah, the right hilum you can see a good number of 1, 2. Probably this is also there 3, maybe 3 or 4. Oh. But the right pulmonary artery is very huge. What is happening to his left pulmonary artery?
But there is no there is no proper visible left pulmonary artery.
No, the left pulmonary is not visible, but the right pulmonary artery is huge, and there is a suggestion that a few endocrine vessels are seen. And how will you diagnose pulmonary artery hypertension by looking at the X-rays?
Sir, one is pulmonary main pulmonary dilatation, yes, and also dilatation of the left descending pulmonary artery.
Okay.
And then abrupt pruning, more than 50% reduction in the diameter. Yes. Then the peripheral 1/3 oligomia with the pruning of the pulmonary vessels.
Pruning, that is a correct word. There is a pruning of the pulmonary vascular tree, and this is known as what is the name given to it? Centralization. Yes. The pulmonary vessels are concentrated around the center, that is near the hilum. They are large there, but as you go to the periphery, it is cut off. That is because of the pruning. And as you rightly said, when you look at the lateral 1/3 of the hemithorax, usually there will be very few vasculature, indicating that the patient has developed because of the pulmonary hypertension. There is a pruning and peripheral cutoff. So is this patient having pruning?
Yes, sir.
Yes,
because the right pulmonary right descending pulmonary artery after this thing, there is no continuation below, sir. See, you can see a huge right pulmonary artery, very huge, and you can see some endocrine vessels here. And as you go to periphery, nothing is here. On the left side is very little. On the right side, you can see the large vessel here, but towards the periphery, nothing is seen. So there is some suggestion that patient may be having shunt because of the increase in the pulmonary endocrine vessels are seen. The pulmonary vascularity is increased, and there is a peripheral cutoff because of which the periphery is almost oligemic, and that suggests that the patient may be having increased pulmonary arterial pressure. So if a combination of shunt plus pulmonary arterial pressure indicate what lesion? Shunt and Eisenmenger, sir.
Eisenmenger. So you have to think that this patient may be having an Eisenmenger syndrome. And what may be the site of the shunt? Is it in the atrial shunt, ventricular shunt, or a great artery shunt?
Sir, if it
Just
is
a minute. Can you wait? Just a minute. Just a minute.
Right.
Hello. Hello, Manjunath. Hello. Hello. Okay. In this X-ray, you have got evidence of the.
Sir, we have to see one is there any cardiomegaly or a normal cardiac shadow and aortic dilatation and any calcification, ductal calcification,
Okay.
or any less prominent of aorta. So these features we can decide about AST or VST or PDA.
Okay. And what is your comment about this patient? What is your name?
Sir, I'm Arun Kumar, sir. Arun Kumar.
Arun Kumar. From where?
I'm doing my DNB in Ramesh Hospital, Vijayawada, sir.
Vijayawada. I think you are very confident. Very good. Excellent. Okay.
Sir, in case of so here there is a slightly cardiomegaly is there, sir. Slight.
Okay.
So with slight cardiomegaly with Eisenmenger features, it goes in pairs of AST, sir.
Okay. The cardiomegaly with Eisenmenger feature is more in favor of ASD. I agree with you. Okay. What about the aorta in this patient?
But aorta is not prominent, sir.
No, but it is not small because usually in ASD, what will happen to aorta?
Aorta is not prominent.
Usually it becomes very small because there is it's only small quantity of blood reaches the left ventricle, and usually the aorta will be smaller in size. What is the shunt lesion in which aorta can be prominent?
VST, sir.
Not VST.
PDA, sir. PDA.
In PDA, you can get the aorta can be slightly prominent. So, does this patient having the ductus calcification?
It's not seen, sir. Ductal calcification because
What is this?
Oh yes, sir.
Can you see this?
Yes, sir. Yes, sir.
This is a ductal calcification.
And sir, there is huge left atria enlarged, sir.
Yeah, there is a left atrium also. There is also the double shadow indicating that left atrium also is enlarged. So enlargement of left atrium is also feature in favor of
PDA, sir.
PDA, not in favor of ASD because ASD left atrium is never enlarged. Then what will be your explanation for this oligemia of the left lung field?
Sir, PDA with Eisenmengerization.
That's right, but then you should be able to see the vessels on the left side also. Here, practically very little vessels are seen on the left side.
Sir, site of yes, sir. On the left side, sir, it decreases in PDA. That's what cause. Yeah, on left side, sir, it decreases. Sir, cause I forgot.
No, here it is unusually small. See, the vessels seen on the left side are practically very little. I cannot clearly see the left.
Sir, yes, sir. Left pulmonary artery stenosis may be present.
Yeah, very good. Left pulmonary artery stenosis. If there is a associated left
in
pulmonary artery
rubella, sir. Yeah. Sir, rubella syndromes are usually associated with PDA and branch pulmonary artery.
Very good, excellent. So that's where you have to think. This patient is having a PDA, Eisenmenger syndrome, and the left pulmonary artery is not clearly seen, or maybe the pulmonary artery, the pulmonary vasculature, pulmonary vessels on the left side are significantly rudimentary, and most likely the patient may be having an associated left pulmonary artery branch stenosis. And this combination of the pulmonary branch stenosis with the PDA occurs in rubella syndrome. Very good, Saroj, excellent. So that's how you have to look at the whole thing. So there is evidence of left to right shunt. There is evidence of pruning. The right pulmonary artery is huge. Left pulmonary artery is not clearly seen. The aorta is, I would say that maybe on slightly on the higher, on the larger side. You can clearly see the ductal calcification. Right atrium is enlarged. Explanation. What is the explanation for right atrial enlargement?
Probably patient who had a LV because
Is the right atrium enlarged in
No,
usual
sir.
PD?
No, sir. This is LA enlarged only, sir, not RA.
No, but I think I agree that there is some degree of RA enlargement also. I agree, LA enlargement is there some superimposition of LA and RA enlargement, but I had a feeling that RA also is enlarged. What could be your explanation? Only explanation is there in a patient with pulmonary artery hypertension. Some of these patients can develop some degree of tricuspid regurgitation, and it may be secondary to the tricuspid regurgitation that the patient might have developed right atrial enlargement. I agree with you that mostly it is left atrium, but I also felt that there is a right atrial enlargement. The only explanation that you can offer is that this patient may be having associated pulmonary artery hypertension. The patient might have developed some degree of tricuspid regurgitation, and that may be the reason why the patient is having a dilated right atrium. So that's the way you should discuss. You can clearly see the ductal calcification. You can also see that there is a disparity between the right and the left side vascularity, and that can be explained by the stenosis of the left pulmonary artery, and the combination of pulmonary artery stenosis with patent ductus arteriosus occurs in rubella syndrome, and hence you have to suspect a possibility of associated rubella syndrome in a patient with Eisenmenger syndrome. Okay. Anybody, somebody else should try now. See, I think all of you should try so that you will get used to seeing the X-ray well. You can diagnose correctly.
So this is a chest X. Sir, this is a chest X-ray.
Oh. What is your name?
Sir, I'm Arun Kumar, sir.
Arun Kumar. Oh, right. Arun. Yes.
Yes, sir. So
Arun from Ramesh Institute. Okay.
yes, sir. Yes, sir. Yes.
Very good. I have come to Ramesh Institute for DNB inspection many years ago.
Oh, okay, sir. Okay, sir.
The good place, and Ramesh is very nice person. Excellent.
Oh, okay, sir. Okay, sir. Thank you, sir. Thank you, sir.
Right. Okay. Yes.
Sir, this is chest X-ray. View wise is a PF view, sir.
No.
So coming to the cardiac shadow, sir. So there is a cardiomegaly, sir. Cardiomegaly is a
cardiomegaly. Yes, significant cardiomegaly. Yes.
Significant cardiomegaly, and even like cardiomegaly, and also even the RA enlargement also is there, sir, and also
I agree. RA enlargement is there. Yes. What about the pedicle? Is it a broad pedicle, narrow pedicle?
Narrow pedicle, sir. Narrow pedicle.
So the vessels are small. So obviously means pulmonary artery and aorta must be small. Okay.
Yeah. Yes, narrow pedicle, cardiomegaly, and pulmonary vasculature appears to be reduced to pulmonary vasculature.
So now, what do you think about this? There is a slight bulge here. What is this bulge, Jude? There is some bulge here.
That is left atrial appendage.
Does it have the shape of the left atrial appendage?
No, sir.
No, sir.
Sir, RVOT, sir.
RVOT. It is an RVOT dilatation.
Yes,
what are the conditions in which RVOT can be dilated, Arun Kumar?
One is Epstein's anomaly, sir.
Very good.
Other one is right ventricle cardiomyopathy. I mean,
RV endomyocardial fibrosis. Very good.
cardiomyopathy fibrosis.
3.
Arrhythmogenic right ventricular dysplasia.
Okay, not very common. When there is a large flow, for example, in a patient with AST with mitral stenosis, the torrential flow to the right ventricle. Sometimes the right ventricle body dilates and also outflow can dilate. So there can be prominent RV outflow dilatation can occur due to 2 mechanisms. One, if the inflow cavity or the inflow part of the RV is dysfunctional or used up, that will result in the volume of blood coming to the right ventricle, coming to the RV outflow, and the RV outflow dilates. In a patient with RV endomyocardial fibrosis, there is obliteration of the body of the RV, and hence the RV outflow dilates. In a patient with the Epstein's anomaly, what happens is part of the right ventricle, the inflow portion of the right ventricle is atrialized, resulting in a smaller cavity, and the RV outflow dilates. So anything happening to the inlet portion of the RV can result in a dilatation of the outflow region. 2 examples are Epstein's anomaly and RV endomyocardial fibrosis. Second possibility, when there is a large volume of blood coming to the RV, so large that the RV body alone is not enough, there is a dilatation of the RV outflow also, which can occur in a patient with large flow ASD, or it may be in a patient with Gutenberg syndrome, where the flow across the endocrine septum is torrential, and this patient sometimes can have a dilated RV outflow also. Okay, so you have to think of the possibility of RV outflow. So all things put together, what do you think about what is the most likely diagnosis? You describe right atrium is enlarged, there is a cardiomegaly, narrow pedicle, no prominent pulmonary vasculature, and there is a bulge in the the left border of the heart near the region of the RV outflow, which you are interpreting it as RV outflow dilatation. All this put together, what should be your diagnosis?
Epstein anomalies.
Epstein anomaly. Very good. It is a case of Epstein's anomaly where the dilatation of the right atrium, the cardiomegaly, narrow pedicle, all are in favor of a diagnosis of Epstein's anomaly. So it's a case of Epstein's anomaly. Very good. Okay. Can you take this X-ray?
So this is just so this is chest X-ray peer view.
Okay.
So coming to the cardiac shadow, so there is a cardiomegaly in the form of RV enlargement and RA enlargement, and also there is a pulmonary artery.
Why did you say RV enlargement? How can you be certain about RV enlargement? RA, I agree with you, but why did you say there is an RV enlargement?
Sir, that angle between the diaphragm and cardiac apex, it appears to be acute, sir.
Not very much acute, borderline. So you should be careful, because if I am asked to comment whether it is a LV type or RV type, I would have said that it is difficult to be certain. If the apex dips down below the diaphragm, you can say that it is LV type. And if it is lifted up with an acute angle between the cardiac shadow and the diaphragm, then you can definitely say that this is a RV type of an apex. Here, you have to be a little more diplomatic, but I fully agree with you that if the examiner tells you that of the two, LV and RV type, which is more likely, I agree with you that's RV type. Yes. Okay.
Then there is a main pulmonary artery dilated, sir.
Yes, main pulmonary.
And right
is prominent.
Right descending pulmonary artery also prominent.
Yes.
And there is a, if you see the end vessels also seen both the perihilar areas, sir.
Yes, in the perihilar area you can see good number of end vessels on the right side. Here you can see one, or here in the hilar region maybe a few more. So obviously this is a shunt lesion. Okay. So in a shunt lesion where the right atrium is enlarged, what is the diagnosis?
Right atrium enlargement via AST, sir.
AST. So whenever there is right atrial enlargement in a shunt lesion, it is ASP. If the aorta is enlarged, it is PDA. And both aorta and the left atrium both are not enlarged, then you can confidently go for a VST. Okay, yes. What do you find here?
Sir, VSR.
VSR, very good, excellent. VSR on a there is a septal aneurysm also.
Yes, sir.
You can see there is a septal aneurysm, the septum is stretched out and that's resulted in a VSR. So there is a VSR with a septal aneurysm. Very good. What is the treatment?
Sir, because sir, this is so surgery is the treatment. Sir,
Yes.
but sir, two types we can do. Sir, if within 24 hours or sir, after 72 hours. And two types like sir, if it is with the anterior wall MI or whether it is with the inferior wall MI. So this
Okay.
looks like maybe anterior wall MI because near apex. Sir, so best is surgery, sir. After doing the angiography, sir, CABG plus VSR repair.
Okay. Usually, if the patient is acutely ill patient, you cannot send for surgery because they may
Yes, sir.
die on the table. But if the patient has become stable and the patient like this was developed a ventricular endoventricular septal aneurysm and it has ruptured, and also the patient is seems to be stable, and these are patients who will do very well with a surgical procedure, and they can be subject for a surgical treatment. Patients who are acutely sick and they are having or hemodynamically almost completely unstable, the surgery in these patients carry a very high risk. There, I think the option is that you may be able to do a device closure. What are the problems of device closure? As well as surgical treatment in the acute phase.
So because there is a acute, so necrosis is there, so the suture will not be taken or the device will
Very
not
good.
be taken.
There's a
So it
friable
may
tissue.
embolize.
Yeah, it's a friable tissue, and so suturing is extremely difficult. And even the device, when the device is placed, it can quickly become unstable and may get dislodged. So, because of the friable tissue, any acute process, intervention, either in the form of interventional treatment or surgical treatment, carries a significant risk. Okay, so this is a ventricular septal rupture.
And sir, in this case, sir, we will do together with, sorry, sir, for aneurysm, sir, we will do the plication. Plication.
Yeah, here in this patient, surgery is better because the aneurysm can also be tackled.
Yes.
Otherwise, the aneurysm is there that can interfere with the cardiac performance, and the patients can progressively develop LV dilatation. So the aneurysm also should be tackled. So surgical intervention will be the more appropriate treatment option in this patient because he has become, if I remember correctly, yes, already about 3 or 4 weeks ago that he had the myocardial infarction and he's stable now, and he will be a good candidate for surgical treatment with a resection of the aneurysm. Diagnosis.
Interventricular septal bouncer, septal bouncer, septal bouncer.
Oh, what else?
The D-shaped septum with
Yeah.
RV dilatation.
No.
And sir, sir,
You're right. It is a D-shaped.
During systole, it is increased D shapes. So appears to be pressure overload. RV pressure overload, sir.
pressure and volume both.
Yeah, there is a volume overload as well as pressure overload. But do you think that the pressure in the RV is suprasystemic or maybe near about LV? Or equal to LV?
It looks equal, sir.
Yeah, it is because there is a bulge during systole. There is a early phase. There is a bulge of the endoventricular septum onto RV, indicating that probably the RV pressure is not suprasystemic. So this was a D-shaped LV. D-shaped LV suggests severe pulmonary artery hypertension, and if the D shape is retained even during systole, that usually indicates that there is a suprasystemic pulmonary artery pressure. But here you can see a bulge of the intraventricular septum into the left ventricle during systole, early phase of systole, indicating that probably the RV pressure is not suprasystemic. So this is a case of severe PH. Okay.
Sir, usually, sir, we don't see tricuspid valve, but sir, here tricuspid valve is also seen, sir.
Yeah, tricuspid
Because-
depends. Sometimes you can see, but here is
Yeah.
the tricuspid also is seen. Okay. Hemodynamic data. Somebody or some volunteer to discuss.
So shall I?
Oh, you
Shall I
can
try?
Yeah.
I'll try, sir. So a 3-month male child, cath data, sir. We'll move on to the first pressure data, sir.
Okay.
RA pressure A is 8, B is 9, and mean is 7.5, sir. So it's slightly rise, sir.
Yeah, slightly elevated. I agree. Usually
Elevated.
the up to 8 people say it can be taken as normal, but I would agree with you that it is an upper limit of normal or slightly elevated. B is definitely abnormal. We cannot go above 8, so 9 is abnormal. Okay, right. There's slightly elevated right atrial pressure. Okay.
And RV systolic is 60, diastolic 80. RV systole is elevated, and diastole is upper limit of normal, sir.
Okay, and there is no gradient across the.
No gradient in pulmonary artery, sir, because pulmonary.
No. Before that, you should say gradient across the tricuspid valve.
Sir, there is no gradient across the tricuspid wall, sir.
Why did you say that?
Because the mean and RV diastolic pressure, and also mean RA mean is almost same, sir.
Okay, very good. Or you can also say that A wave is equal to RV and diastolic pressure. So there is no gradient across the tricuspid valve.
Tricuspid wall, sir.
Okay,
Then pulmonary pressure elevated, sir. So, pulmonary pressure systolic 60, diastolic 28, mean is 40, elevated. But there is no
which is elevated? Is it all the 3 elevated or only one pressure?
All the 3 are elevated, sir.
Okay. Is it the moderate pulmonary hypertension, severe pulmonary hypertension? What is the grade?
It is moderate pulmonary hypertension.
Moderate pulmonary hypertension. Okay, right. Okay, yes.
And there is no gradient between RV to PA, sir.
Very good.
So left LA A is 20, B is 25, and mean is 23, grossly elevated, sir, and V is more than A, sir.
Okay. Is it a normal pattern?
Usually in the
Yes, sir. In LA, it is B is more than 8.
we use
only 1 or 2 millimeters. Here it is 5.
5.
Why in LA V is more prominent than A wave?
Sir, 5 in the V more prominent in LA. Probably patient may having weakest.
Oh, here it may be regurgitation, but in general, when you record in LA tracing or pulmonary artery wedge tracing, the V wave is slightly more prominent than the A wave. What may be the reason? While on the right atrium, A is slightly more prominent than the V wave. What may be the reason?
One is the right atrial is left atrium is the position between the spine and
RA is more compliant.
RA is more compliant compared to the LA, sir. Reasons are because we have a pulmonary veins draining and posteriorly spine, and so distension will be less in LA, sir, compared to RA.
No, LA musculature is slightly thicker than the right atrial musculature. It is less compliant, and when the volume of blood coming into the left atrium, the pressure in the left atrium rises faster than the right atrium, and also because of that, the volume of blood coming into the right atrium, left atrium, the pressure rise may exceed that of the A wave. So in a patient with in a normal person, when you look at the A wave as well as the B wave, usually left atrial V wave is slightly taller than the left atrial A wave. It's only marginal. Very often it is equal. Here, but the difference is 5 millimeters, indicating that there is something more is happening. Okay, right. Go ahead.
Moving into the LV, sir. LV systole 85, diastole 20, and coming to the gradient between
No. Gradient between LA and LV.
LV and LV is there's no gradient, sir, because LV endosteric pressure and A wave same, sir.
Okay. Is the LV endosteric pressure normal or elevated?
Elevated. LV endosteric pressure is elevated, so more than 12.
What is upper limit of normal?
Up to 10, 12, sir.
Okay. Up to 10 or 11, it can be taken as upper limit of normal. Here it is 20, definitely elevated. Okay, yes.
LV endosteric is elevated. Moving to the pulmonary femoral artery, sir. Systolic 90, but diastolic 50, mean is 68. So, and so then there's no I think normal pressure, sir, because considering 3 months.
Yeah, it's normal pressure. Agree with you.
But
the pressure in the pressure
LV,
is, the artery is more than the left ventricular pressure. How is it?
sir, actually the LV pressure should be more than the arterial pressure, systolic, but here is less, sir.
Why?
Probably having LV dysfunction, sir.
No. LV dysfunction does not mean that the arterial pressure should be higher than the LV pressure.
Or it may be a shunt, having any shunt.
What shunt?
At the interventricular level, sir, interventricular septum level.
So what? Here, what is recorded here is the femoral artery.
Pulmonary artery is.
No. Femoral artery pressure. See, the systemic arterial pressure is recorded from the femoral artery. So, what is
peripheral augmentation?
Yes, because of the peripheral augmentation, the femoral artery pressure can be the systolic pressure in the femoral artery can be higher than the left ventricular systolic pressure. So here the recording is from the femoral artery, but if it is from the aorta, then it can be an artifact also. But here you have a good explanation that it is the peripheral augmentation of the systemic pressure. We can result in a higher pressure in the peripheral arteries compared to the central aortic pressure. So here the pressure 90 can be easily explained by saying that this is a peripheral augmentation. Okay, right? Yes. So what are the abnormalities in the pressure tracing?
Sir, abnormalities, RA pressure is slightly raised, yes. And pulmonary arterial pressure is high, and LA is grossly high, sir. Grossly high. LV endosteric pressure is high.
Okay. So there is a LV dysfunction, LV endosteric pressure is high. Consequently, LA pressure is high. Consequently, pulmonary artery pressure is high, and also there is some elevation of the right atrial pressure. Okay, right. Yes.
Oximetry, sir.
Is the patient having pulmonary vascular resistance? We are not looking at the oximetry data, but looking at the pressure data. What is the normal pressure drop across the pulmonary vasculature?
Normal pressure drop across if it is a gradient, it should be less than 12, sir, or if it is diastolic, less than 7, sir.
Usually the
7, sir. Transpulmonary gradient, sir.
Yeah, pressure drop. That is a transpulmonary gradient. How much is it?
7, sir.
7.
Say just 7. It's around 7 to 12. Sometimes it can go slightly higher, up to 10 or 11 is possible, but usually it is 7. The pressure drop is around 7. Very rarely it goes above 10. Usually it is around 7, 5 to 7. So here, what is the drop?
20, sir.
Oh, 20.
Or no, the PM mean by 40.
3, sir.
By 40 minus. Sir,
3 only, no, sir.
No, sir. 40 minus 3.
40 minus 23, sir.
17.
So 17.
So 17. So definitely the pressure drop is much more than normal, indicating that there is some degree of pulmonary vascular reaction.
Yes.
So only when there is a pulmonary vascular reaction that the pressure drop goes above 7 to 10. So here there is some degree of pulmonary vascular reaction. Okay, right. Now oximetry data.
SVC 70, high VC 72, sir. So it's a normal SVC is normal, sir. IVC also normal, sir.
Okay.
RA middle 71, lower RA 70. RV inflow and outflow 71, 70. There is no up to here. There is no any stuff up, sir.
Okay.
PA is 76. PA 76. But if looking in PA 76, but RV2 PA is 6. There's step up 6. But if coming to the SVC, IVC mean that it is somewhere around 5, but anything more than 7 significant, sir, from mixed venous to PA step up.
What is the step up required to diagnose a shunt at the arterial level?
5 only.
Arterial 5 only, sir.
5 only. It's 5. Single
Okay,
sample
sir.
as well as multiple samples 5. What is the level required for the ventricle?
Sir, ventricle at level of ventricle is 5, sir.
No.
7.
7 single sample?
Single
5
sample.
5 multiple samples.
Okay, sir. Okay. 5
And,
multiple.
5 multiple samples, single 7. On the pulmonary artery level, it is single or multiple, it is 5. And atrial level?
Atrial level either 7, sir. 7 with single sample.
And?
Sir, 11 with single sample.
Yeah, 10 to 11 for the single sample and 7 for multiple samples. So that there you should know very clearly. So the step up in atrium can be diagnosed if there is a single sample 10 to 11. Some people consider 11, some people consider even 10. At least there should be 10. Better to be 11. 2, it can be multiple samples in the atrium, 7. Ventricle, single sample 7, multiple samples 5. Atrium, at the arterial level, both single as well as multiple 5. So here there is a step up from the RV to pulmonary artery. What is the step up?
6, sir.
6.
6. So it is significant, sir.
Okay.
Then coming to the LA 94. So there, so LV 94, PA 94. So pulmonary vein is not given, but we there is, if you taken as a pulmonary vein normal 98 or 100, then step down in LA.
Okay. What may be the reason?
Step down in LA here.
Is it a step down or is it something? Okay. What are the reasons why the LA oxygen saturation is lower than expected?
Sir, one, if it is less than PV, LA is low because the bronchial veins draining into the LA, sir. That is normal, physiological, where we get to 2% saturation lower than pulmonary vein in LA. But other pathological step down in LA is, one is suppose conditions like ungrouped coronary sinus.
What did you say? What did you say?
Yes, sir.
What did you say? Ungrouping of the coronary sinus. Well, how can in this ungrouping of the coronary sinus? How can there be a step down in left atrium?
Sorry, so coronary sinus draining to LS, sir.
Okay, there is some. Usually, when there is an ungrouping, usually it behaves like an ASD because the pressure in the left atrium is much higher than the pressure in the coronary sinus, and hence the blood will flow from the left atrium through the coronary sinus into the right atrium. So more often they behave like a left to right shunt at the atrial level. Okay, right? Yes.
Then other one is preferential flow from IVC to LA via the patent access arteriosus or ASD, sir. So if in preferential flow through IVC to LA via patent access arteriosus. I mean, just sir. Yes, sir.
What are you saying? I'm not clear because IVC through the patent access arteriosus into the
PFO, sorry, PFO, sir. PFO.
Right.
Sometimes the preferential flow from IVC to LA, sir. That can also have a LA desaturation.
Very rarely, because PFO, is the PFO normally open or is it normally closed?
Closed, sir.
It's closed. When does it open?
Sir, Valsalva and straining, sir.
Yeah, if there is a Valsalva, straining, coughing, sneezing, there can be a transient rise in the right atrial pressure, and that can result in transient right to left shunt in a patient with a patent phenomena. Normally, even when the blood coming from the IVC, even if it is directed towards the intraatrial septum, towards the region of the patent foramen vein, it does not flow like that. It does not flow from right to left. There should be a reason for the right atrial pressure to be elevated for the shunt to take place. And the situations where there can be an elevation of right atrial pressure are straining, 2, coughing, 3, sneezing. These are the 3 situations where you can get sometimes there can be a sudden opening of the patent foramen vein, and that can result in right to left shunt. Okay, right? Yes.
Then sometimes IVC can directly drain into the LSR when anomalies of IVC.
Okay. Anomalous the drainage of the systemic veins into the
Systemic
left
vein-
atrium.
Yes,
The
sir.
LSVC to LA.
LS to LA also comes.
Okay.
Yes, sir.
Any other structural heart disease which can result in a lower pulmonary left atrial oxygen saturation? Any AV canal, any
Yes, sir,
arteriovenous
endocardial
communication?
push.
Any arteriovenous communications?
Sir, endocardial cushion defect. No.
The cardiac cushion defect, of course, that can sometimes, because there will be mixing of the blood everywhere, so left atrial oxygen saturation can be lower. But in a patient with pulmonary arteriovenous fistula, what will happen?
Yes,
In
sir.
a patient with pulmonary arteriovenous fistula, what will happen to the LA oxygen saturation?
So it will decrease, sir.
It will decrease because there is a where there is a pulmonary arteriovenous fistula, there is no oxygenation of the blood, and the blood coming to the left atrium can be deoxygenated. That can happen. Okay. Anything else? Can there be a problem in oxygenation of the lungs?
Yes, sir. Hypoventilation or
Yes,
are
hyperventilation. Or the patient-
physiological anatomical sheds of lungs.
Yeah, if the patient is having interstitial edema, if the patient is having interstitial edema, can it result in for the subnormal oxygenation of the blood coming to the left atrium?
Yes, sir. It's along with the PV saturation also, sir.
Yeah.
Reduced.
If there is a reason for development of interstitial pulmonary edema, or if there is some elevation of the left atrial pressure, where the pulmonary venous pressure is elevated, and there is a possibility of pulmonary edema, these patients can have a oxygen saturation can be less than normal. Do you think that this child is having such a problem?
Yes, sir. Left atrial pressure is high, na, sir.
Yeah.
Sir, so, sir, there may be, sir, stenosis of pulmonary vein draining into
No, but this patient is having a step up at the pulmonary artery level. What are the conditions where you can get a step up at the pulmonary artery level?
One is PDA, sir.
PDA,
AP window, sir.
epi window,
Then this thing.
AV fistula, coronary AV
Alcapa, sir.
Alcapa, okay, Alcapa, very good.
Then this thing, coronary. Coronary, okay, that we already told.
Okay.
Sir.
What are the situations where the pulmonary oxygen saturation can be more than that of the RV saturation? Any man-made shunt?
Yes, sir. Aorta to pulmonary artery connections,
Yes.
like subclavian artery to BT shunt,
Okay, BT shunt, Gortic shunt,
part shunt, water
Port
shunt.
shunt, water circulation. Okay, all these can be. Okay, right. Anything else? Can there be naturally existing collaterals?
This aorta pulmonary collaterals.
Pulmonary collaterals. The the pulmonary collaterals also can contribute to oxygenated blood to the pulmonary artery. So there are many conditions where the pulmonary artery oxygen saturation can be elevated. So in your opinion, what is the reason in this child? The 3-month-old child, there is elevation of the left atrial pressure. The pulmonary artery pressure is already, the patient has started developing pulmonary arterial hypertension. There is a step up at the pulmonary artery level. So what is the most likely possibility?
Sir, one is LV failure, ALCAPA, sir.
LV failure, ALCAPA, very good, excellent. So if there is an LV failure, these patients can have an LV failure, and these patients can have associated what? What lesion? What is the valvular lesion that is associated with
They'll
ALCAPA?
have a left AV valve regurgitation.
Regurgitation. So can that be explained?
Yes, sir, because V wave is 25 in LA, and both A and B are raised, and mean is also raised, and desaturation at LA. So, and also end-diastolic volume of end-diastolic pressure of LV is also raised. So LV dysfunction with LV left-sided AV valve regurgitation.
In what type of ALCAPA you get this type of abnormalities where the LV dysfunction, mitral regurgitation, and left atrial pressure going up, patient presenting with severe LV failure? In which type?
That is anomalous aneurysm left coronary arteries.
Yeah, the anomalous aneurysm left coronary, agreed. Is it this frequently occurs in patients where there is a good communication between the right coronary artery and the ALCAPA, or without communication?
Without communication, sir.
Without communication. If there is no communication, then how can the pulmonary artery oxygen saturation go up?
Oh, yes, sir. It has to have a communication from RV to LA to have a saturation step up at the pulmonary artery. So probably this patient is having good communication with.
Some communication is coming to the pulmonary artery from the systemic side. And there are two important things that you can consider is PDA and AP window. Out of these two, which one you think is more likely?
Sorry, yeah. Sir, at this age, considering at this age, AP window, sir.
Very good, excellent. It is AP window because 3-month-old child presenting with step of oxygen at the PA level, patient in heart failure, all those things make us think that it's more likely to be an AP window rather than PDA. PDA is much more frequent, but considering all the scenario, it's more likely to be AP window. Could you understand that why there is the ALCAPA is a very unlikely possibility?
So the presentation, sir. Presentation.
No. Why did I say that ALCAPA will be an unlikely possibility? Because of the fact that this patient has developed severe left ventricular failure. Left ventricular failure patients are patients of ALCAPA where there is no communication between the right coronary artery and left coronary artery. Only when there is a good communication between the right coronary artery and left coronary artery, and the oxygenated blood drains into the pulmonary artery, then only you can get an oxygen step up at the pulmonary artery level. So it is the one without communication that will be more symptomatic, they develop LV failure, they develop mitral regurgitation and all those things. So this patient most likely is having not a ALCAPA, but most likely an AP window. Okay, is it clear or the discussion?
Fine, sir.
Any doubt you should ask now. So the possibilities where when a child where there is the pulmonary artery oxygen saturation is elevated, it means that there is some oxygenated blood is coming to the right atrium, to the pulmonary artery. It can be PDA, it can be AP window, it can be the man-made shunt, or it can be natural collaterals from the aorta to the pulmonary artery, or it can be ALCAPA, where the communication between the coronary artery and the left coronary artery is there, and the blood is draining from the right coronary artery through the left coronary artery into the pulmonary artery, resulting in oxygen step up at the pulmonary artery level. So that here, but this patient is present. Those patients with good communication from the right pulmonary artery to the left pulmonary artery, they are less symptomatic. They are getting oxygenated blood to their myocardium, and they are less symptomatic. But those patients where there is no communication, they develop severe ischemia to the left ventricle, they develop left ventricular failure, mitral regurgitation. But then, since they do not have a communication between the right coronary artery and left coronary artery, the oxygen step up at the pulmonary artery is not possible. So here, the most likely diagnosis is the patient with having a AP window, LV failure, and even the patient has started developing significant pulmonary vascular resistance has gone up.
Sir, little I could not understand, sir, with communication and without communication. So it means that if communication is present, patient will go more in failure than
if the communication is present, what happens hemodynamically? The blood from the right coronary artery can drain into the left coronary artery. So that can supply the left ventricle with oxygenated blood. If there is no communication,
no communication means, sir, left side is not getting blood, so there will be more ischemia, more failure.
No. If there is no communication, the left ventricle will not get adequate blood. The oxygenated blood is not coming to the left ventricle. The patient will develop myocardial ischemia, and they can develop LV failure. They can have associated papillary muscle dysfunction, mitral regurgitation.
So, sir, if communication is present, then, sir, there may be a step up at the pulmonary artery, but, sir, LV will not be ischemic.
Well, you will not be ischemic, yes.
Okay.
Because the communication is diagnosed clinically by looking at the continuous murmur. So it is said that an alcapa, where there is a normal alcapa which makes a noise, is less serious than the alcapa which does not make a noise. Would you get the point?
Sir, make the noise means, sir, more flow.
Continuous murmur.
Sir, flow is so communication is present.
Yeah, communication is
Okay,
present.
sir.
Continuous murmur indicate that there is a communication is present. So the left ventricle will get adequate oxygenated blood. These patients present later in life, and they can survive infancy without any problem. And later in life, they may start developing some ischemic symptoms, and many of them may require a surgical treatment, where either the left coronary artery can be re-implanted into the aorta, or sometimes the coronary artery arising from the pulmonary artery is ligated, and a graft is placed from the aorta to the left coronary artery. So those those patients with the alcapa having a continuous murmur has got a higher possibility of survival into adulthood or into teenage, and they will be able to undergo a corrective surgical procedure. The one which does not make a noise, usually they are more serious, more sick, LV failure, and all those things, and they may not survive. Is that clear why
yes, sir. Thank you, sir.
Yes.
Yes.
Thank you, sir.
Okay, yes, maybe we'll go to the next one. What does the echocardiogram show? What does it show? Is it a transthoracic or transesophageal?
Transesophageal, sir.
Transesophageal. Why do you say that?
Sir, because that logo is there, sir, on the right side.
No. You should. The answer should be that the chamber close to the transducer is
sir, it will be LA.
LA. So the chamber in a transthoracic echo, LA will be farthest from the transducer, and transesophageal echo, it will be closest to the transducer. That should be your answer. You should not say that the logo is there, so I have diagnosed that it is transesophageal echo.
Sorry, sir.
You can always make use of that, but your answer should be intelligent enough to say that it is because of the left atrium is closest to the transducer. The answer should be that. You can always make use of this logo. I agree with you that once you see the logo, you are sure that it is a transesophageal echo. That is right. I fully support your statement. But in the examination, you should say that the cardiac chamber closest to the transducer is left atrium. Okay, right. Yes.
Sir, LA mass is there, sir.
Yes.
Sir, occluding to the to the mitral valve.
Okay. It is falling onto the
protruding.
mitral valve. Okay,
Yes, sir. Yes, sir. Sir, there is possibly, sir, left atrial myxoma.
Yes. Most likely it is left atrial myxoma, because in one view you can see that the mass is pedangulated, it is moving and is dropping into the mitral valve intermittently. So all put together, a very mobile, very fragile.
And sir, the echogenicity is, sir, variable, little.
Yes, yes. The variable echogenicity is a feature of the left atrial myxoma. What are the chambers? Which are the cardiac chambers where left atrial myxoma is common in the order of frequency? Of the 4 chambers, which are what is the order in which the myxomas occur in each of these chambers? Commonest is
LA, sir.
LA, followed by
RA, sir.
RA, followed by
RV.
no LV, and it is the rarest in RV. It is LA, RA, LV, RV. So it is the rarest in RV. It is commonest in left atrium. Okay, so left atrial myxoma. I think we will skip this. Okay, what is this?
So thrombus in transit.
Yeah, very good. So transit through.
Sir, PFO or ASD small.
Yeah. No, it is not ASD because
It's a PFO.
it is PFO. It is the
Dumbbell shaped.
thrombus and transit through the PFO. This patient presented with a stroke into the neurology department, and they sent the patient for an echo examination to rule out any cardiac cause for embolism and stroke. And when we did the echo, we found that this patient is having a thrombus in transit through the. You can see that. Did others see also? Everybody, could you make out? So this is the clot in transit. You can clearly see it here. You can see it here also. A clot in transit. It is going through the patent foramen vein from the left side to the right side, and from the right side to the left side, and that has resulted in systemic embolism and stroke in this patient. So this is a case of thrombus in transit through the patent foramen vein. You can see it very clearly here. Did all of you see that? That's very important to see. It's not very common to get this. We fortunately got this where the patient presented with stroke. The patient was referred to us, and then we could make out that this patient is having a thrombus in transit through the patent foramen vein. We anticoagulated the patient, and within 7 days, everything disappeared. Patient became perfectly normal. There's also possibility it might have disintegrated and gone into circulation, but at the end of 7 or 8 days, everything had disappeared. The patient became perfectly normal as far as the clot is concerned. So this is a clot in transit. Nothing special. It's only a patient with pulmonary hypertension. You can see the D-shaped left ventricle, and here the D is present during systole as well as diastole. So indicating that most likely the pressure in the right ventricle is equal to or more than that of the left ventricle. So here is the D-shaped left ventricle where the D is almost remaining flat during systole as well as during diastole. Okay, we'll go to the next one. Okay, what is this and what is your interpretation? There should not be any problem. This is the lung
The
ultrasound.
chest, the lung ultrasound showing B lines.
B lines, yes. Which one are the B lines?
So in the second one, sir, vertical lines which are seen up to 3 to 5.
More than 5, up to 5.
More than 5. Yes, sir.
Right. So here you can see multiple lines, 1, 2, 3, 4, plenty. So this is a case of what is the interpretation?
The pulmonary edema.
Fluid in the lungs.
Fluid in the lungs.
Almost causes pulmonary edema. Sometimes you can sometimes get in patients with ARDs also. Sometimes you can get B lines, but if there are plenty of B lines, then almost always it is due to a cardiogenic pulmonary edema. So pulmonary edema is the reason for these B lines, and actually this is the ultrasound scan in a patient with COPD, and this is a normal patient, normal individual. This is COPD. This is patient who is having acute breathlessness secondary to interstitial and pulmonary edema. And so in the emergency department, it is extremely easy to differentiate a patient with pulmonary edema from a patient with COPD like presentation. So this patient is having COPD and this patient is having acute pulmonary edema. Okay, this is the, oh, sorry. This is the CT. You have to interpret the CT. What do you find there? What is this structure?
Sir,
Yes.
Sir, aorta, sir. Aortic aneurysm.
This aortic aneurysm pressing on the pulmonary artery. Oh, sorry. What all things can you make out in this CT? Of course, aorta is grossly dilated. Aorta is pressing on the pulmonary artery. What else is there? So there is an aortic aneurysm. Anything more?
The flap is seen
What is
in the
this?
aorta. Yes, sir.
What is this?
Flap, sir.
Yeah. What does it indicate?
Sir, it
Dissection.
is
Dissection. There is an aortic dissection also. So the aorta is grossly dilated, aneurysm and aortic dissection. When this combination occurs, what should you suspect?
Aortic aneurysm with dissection, sir.
Yeah.
the Marfan's.
Yeah, very good. One is Marfan syndrome. 2.
The other DL syndrome, sir. Other
Ehlers-Danlos.
Common category. Collagen disorder syndromes. Yes.
yes, collagen, sir.
And also you should think the possibility of aortopathy in a patient with bicuspid aortic valve. 2 important things which should cross your mind is collagen disorder like a Marfan syndrome, Ehlers-Danlos disease. All this can give rise to aortic aneurysm as well as aortic dissection. And second thing that you should think of the cross your mind is a patient with aortopathy in a case of bicuspid aortic valve, they can have aneurysm as well as dissection. So these are the two important things which should cross your mind. Okay, so this patient actually had a bicuspid aortic valve with aortopathy and had a dissection, and this patient underwent Bendal procedure and is doing extremely well. This is a MR angio, and what is your diagnosis?
So the left subclavian artery cannot be seen.
Oh,
Oh, okay.
left subclavian artery cannot be seen.
Oh, sir, sorry, sir.
You do not know whether it is.
That is the right side, sir. That we can.
I agree with you. The right, the left subclavian artery is not really seen here.
So, but there is communication with this ascending aorta dilated with the
Okay.
chamber communicating with the ascending aorta.
What is it?
So
It's also aneurysm, sir.
No, actually, it turned out it is actually a case of AP window.
Okay.
And what you are seeing here is actually, because unless it is moving, you cannot make out. So this was actually a case of AP window with a large communication between the aorta and the pulmonary artery. So it's a case of AP window. Where you can see large aneurysm, large. It appears as like a outpouch from the aorta, but actually it was a AP window with opacification of the pulmonary artery. I don't remember whether the left subclavian vessel was patent or not. I agree.
No, sir, this is spatial only, sir. At that cut, it may not be there, sir.
Yeah, I know unless you have multiple cuts, you can't be certain
Yes,
about
sir. Yes, sir.
you have to see that. So here also, unless you see multiple cuts, you may have difficulty in interpreting what may be this mass. This could even be, as somebody has rightly pointed out, it can be an outpouch from the aorta, but it finally turned out to be a AP window communication between the aorta and the pulmonary artery. This is an MRI, cardiac MRI, CMR for diagnosis, and what is the value of CMR in such patients?
HOCM.
Yes, it was very good. It is
Sir, yes, sir. We have to see, sir, LGE. If more than 15%,
yeah,
then, sir, we have to go for ICD.
yeah. Now, what did you say?
Sir, LGE,
Oh,
late gadolinium enhancement, if more than 15%,
Very
suggest fibrosis.
Yes.
And we have to, this is a high risk candidate, so ICD, if
Yeah.
young.
yeah. There is patients where fibrosis is the one which decides the arrhythmia. So if the patient is having on MR angio, late gadolinium enhancement, indicating the fibrosis more than 15%, these patients should undergo an ICD implantation, and that has been shown to be beneficial. Is there any new drug available recently?
Yes, sir.
tough medicine.
No, sir.
No, mavacamten.
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 Yes, sir. HCM Explore trial.
Yes, yes. Okay. How does it act?
It inhibits the myosin binding with the actin. That force of contraction will be reduced.
Yeah, very
Yeah,
good.
there is a negative inotropes.
Yes, there's been shown there's some beneficial effect in the symptoms of the patients with hypertrophic cardiomyopathy, but not yet certain whether it can alter the natural history. But symptoms can definitely come. So this is a new drug which is coming in the treatment of this patient, and it may be an encouraging thing. Okay, right? Yes. Okay, I think we'll stop at that level. Next class, what should we have? Should we have a case discussion, or do you want something different?
Case discussion, sir.
Okay, so next week we'll have a case discussion, and subsequently we'll decide what to do. Okay. Any doubts about things which I have told you? If you have got any doubts, you can ask now. Any doubt about any of the spot tests that we discussed, starting from the electrocardiogram to the MRI and CT angio? Okay, great. If there are no more doubts, then we'll stop at this level. Next week we'll have a case discussion. Okay, great.
Thank you very much, sir. Thank you very much, sir.
Thank you, sir.
Good night.
Thank you, sir.
Good night.
Thank you, sir.
Okay.
So, sir, with your permission, shall we conclude?
Oh, we can conclude. Yes, thank you.
Okay, thank you, sir. So, from here now, I'm ending this meeting. Good night, sir.
Good night.